starting here in the hospital called Tecousin. Tecousin is the brand name, Dofetilide, the generic. And Tecousin's a little different than most other antiarrhythmics. Tecousin is a drug that is approved for treatment of atrial fibrillation and atrial flutter. And it's different because of its mechanism of action and the way we initiate it. We have several classes, 4 classes of antiarrhythmic drugs. Class 1 are beta blockers, class 2 calcium channel blockers, class 3 are kind of like a mishmash of drugs. Actually, class 4 is the calcium channel blockers. Class 1 has drugs that can only be used in people with structurally normal hearts. So Tecousin or Dofetilide is in the class 3 of antiarrhythmics. Tecousin is an antiarrhythmic that's been out for probably 10 years. When it first came out, for the first 4 or 5 years, you actually had to get certified to prescribe the drug, because it has all these little idiosyncrasies about the drug that you have to understand when you dose the drug. So now, no certification is necessary. Any physician can write for it, although most don't. Usually cardiologists and electrophysiologists write for the drug. So Dofetilide is an antiarrhythmic agent that is very effective to both treat and convert people from atrial fibrillation to normal rhythm. It's probably one of the most effective antiarrhythmic agents that we have. Of all the drugs that we use to treat atrial fib, this is the best drug to get somebody into normal rhythm without having to shock them. It's one of the reasons why we like it. It's also very well tolerated. Most patients do very well with this medicine. The most common side effects I hear about is occasionally dizziness. But the most important thing is you want to watch out for drug interactions and the effects on the electrocardiogram. Rarely have I seen patients have a rash with this medicine. Some patients complain of nausea, but if so, it's very mild. So from that standpoint, tolerability is really good with this drug. This medication works on a certain part of the electrical system, and that's why I'm going to give you this one to start, so you can understand a little bit this graph of the normal conduction system and how it affects the electrocardiogram. So if you look in the upper left part, it says atrial depolarization. That's, as you know, the upper chambers of the heart contracting, and that's depicted on the electrocardiogram by the P wave. After atrial depolarization, there should be no electrical activity going through the heart, so you have a flat line before you get to the QRS complex. The QRS complex, as you can see here, number 2 is the PR segment. Number 3 shows ventricular depolarization. So when the left ventricle contracts, you have depolarization of electrical activity, and then it repolarizes to get ready for the next beat. Tecousin affects repolarization. It does not affect depolarization. So the QRS complex, which is when the bottom chambers of the heart, the ventricles contract based on the electrical activity that it generates, that's the depolarization. That is not affected by Dofetilide. What Dofetilide does affect is repolarization. So number 4, you can see at the end of the QRS complex, depolarization is done at the very end of the QRS complex. And then from the beginning of the ST segment all the way through to the end of the T wave, that's repolarization. Okay? That's the part on the electrocardiogram that Dofetilide affects. Okay? Any questions about that part? It's really important to understand that, because if you see changes on the electrocardiogram, you want to know, is it drug related or not drug related. So if you look on this second EKG, this is a normal electrocardiogram, okay? And there are different intervals that the computer picks up. I have to tell you, computers aren't necessarily as smart as they think they are. Sometimes that calculation is inaccurate. I'll give you an example of that. So if you look on right in the middle of the EKG, there's rate, PR, QT, and then QTC. Okay, and then below that says QRS SD. That's the QRS duration. Right there in the center of the chart. So the areas that we're interested in when we use a drug like Dofetilide are the QRS duration and the QTC, which stands for the corrected QT interval. Okay. Why are we interested in the QRS duration? The QRS duration tells us when you figure out the corrected QT interval, it calculates it based on the QRS complex and repolarization. So it takes into account both depolarization and repolarization. Okay? So it can mess up your calculation of what we're actually looking for with the dofetilide. So normally, you can see the QRS duration is 80 milliseconds. That's normal. That's how fast normal conduction is. But the corrected QT interval, that's what we're looking for dofetilide. So if somebody has a normal QRS duration, less than 120 milliseconds, we can use the calculation most times that the computer prints out as the corrected QT interval. The important thing with dofetilide is that because it works on repolarization, it's going to prolong that corrected QT interval in everybody. We know it will. We don't want it to prolong too much. If it prolongs too much and you have a PVC that happens at just the wrong time, you can have ventricular fibrillation or torsade. That's why they're here for 3 days to get started. The most common time for that QT prolongation to occur is in the first 3 days of starting the drug. Okay? So the things that I need to know when we start this drug is, has the corrected QT interval dramatically increased? Has it gone to more than 500 milliseconds? If it's gone to more than 500 milliseconds, we have to cut back the dose. We dose dofetilide based on two things, on the creatinine that we draw every day and the electrocardiogram. When we get those two pieces of information, we know what the right dosage is for the patient. So I calculate what's called the creatinine clearance. There's a formula for this. And you plug in the patient's age, and you plug in their weight, and you plug in their creatinine. And that tells me the creatinine clearance. If your creatinine clearance is greater than 60, you get 500 micrograms of dofetilide every 12 hours. If your creatinine clearance is 40 to 60, you get 250 micrograms. And if it's 20 to 39, you get 125. That's the dosing of that drug. Okay? So that's why I get an EKG a couple hours after each dose and make sure that that hasn't prolonged. It will prolong, just as long as with a narrow QRS, normal QRS complex, less than 120 milliseconds, it's not more than 500. If it's more than 500, I need to know, because I gotta cut back the dose. I don't have to know immediately, because the next dose isn't due for 12 hours, okay? Or 10 hours after that EKG. So if it comes in 3 hours later and it's 2 o'clock in the morning and the next dose at 10 a.m., you don't have to call me at 3:30. You can, because you're not gonna give a dose anyway. They're there for you to watch. If they have an arrhythmia, yes, then I need to know, okay? Because if they have the arrhythmia, then they have to give them something that shortens the QT interval. Lidocaine does that, okay? Or increasing the heart rate. Those things do it. So you can use isoproterenol if we have to, but we really will have to do that. So that's why we get the EKG. And it's not an emergency to call me right away, you don't have to worry about that. But as long as I know before the next dose is administered, that, hey, look at the EKG, it's gone more than 500 milliseconds, you want to cut back the dose. Or if the creatinine's bumped up for whatever reason, then I need to know, because it affects the calculation, okay? So that's why they're here for 3 doses, and we just dose that way. To take it a step further, let's look at the next EKG. The next EKG is a patient that has a pacemaker, okay? So the pacemaker, if you go to the little line that says QRSD, that's QRS duration, and compare it to the last EKG. The last EKG had a QRS duration of 80 milliseconds. With a pacemaker, it paces the ventricle, okay, usually near the apex, so conduction is really slow through the entire ventricle. You don't get this really fast depolarization. It's slow because you get the pacer spike that kicks into the ventricle, and then that electrical activity disperses around to both ventricles, and that takes time, okay? Not as fast as a normal conduction system, unless you put your lead right on the conduction system, and then it would be normal, which you can do, but not with this. You can see on this. This is a regular pacemaker. This is what you're gonna see 99% of the time. So the QRS duration went from a normal of 80 is now 146. It's gonna throw off the calculation of the corrected QT interval when you have a pacemaker, or if you have a left bundle branch block. Sometimes even with the right bundle branch block on the EKG, it can mess up what the computer says is the corrected QT interval. If you go back to the first strip, on the first depiction here, it says, remember we were talking about depolarization is here, and the dofetilide effects here. If this is prolonged and you calculate from here to here, it's gonna be longer than what it really should be for dofetilide. So it's gonna mess up your calculation. What I'm interested in is what happens from the end of the QRS complex to the end of the T wave.
Right.
Because that's where it works. So when you have somebody with a pacemaker and you have somebody with a left bundle branch block and we're not sure what to do, call me. I'll look at the EKG. The calculation is that we don't give dofetilide if the QRS duration is greater than 550 milliseconds because you get that wide QRS. If it's greater than 550, I usually cut back the dose. So 500 milliseconds if you have a normal QRS complex, 550 milliseconds if you have a bundle branch block or you're paced. Okay. In most cases, if someone develops QT prolongation, we know right away because we're watching them like a hawk. And if that QT prolongation occurs, we either hold the drug or we decrease the dose. It is very, very rare to see torsade with these patients. But you want to have a defibrillator around. That's why they're here. And if they go into VFib, we shock them. Okay, and they don't get any more pills. That happens. Okay, but usually I can tell. Yeah, I'm seeing it going a little bit longer, and then finally, if it goes more than 25% of the initial QRS, the initial QT interval, I'm stopping the drug.
Mm-hmm.
So I'm watching this too. And obviously, since it's new here, I'll be watching it even a little closer here. But if there's a question, you take a picture of the electrocardiogram. I'll give you my cell phone number, take a picture, send it to me. I'll look at it, see if it's okay, it's not okay. But the important thing is that if you don't want to be married to whatever the computer says the QRS duration is. Because these patients need this drug. There are only 3 drugs that we can use if somebody has coronary artery disease to treat atrial fibrillation. 3. There's this drug, there's sotalol, which makes most people sick and drops their heart rate significantly, and there's amiodarone. That's it. And with amiodarone, you can get all sorts of complications and side effects. You know, pulmonary toxicity, liver toxicity, thyroid toxicity. You have to wear high-grade sunblock if you go outside because the amiodarone with the iodine portion can turn your skin a slate gray color that doesn't go away. Yeah, it's got a lot of side effects, so it's not my favorite drug if you're in your 60s and you have AFib and you need to be treated with a medicine. So if you're in your 80s, 90s, maybe, but still, you know, it's not my favorite drug. And if you have a side effect with amiodarone, you have a side effect for a long time. If you have a side effect with dofetilide, in 2 days it's gone. So the important thing with these patients also is we tell them don't miss any doses because the present recommendations are if you miss 2 doses of dofetilide, you got to come back in the hospital for 3 days to restart the drug. Because you can, if you start and stop, that QT prolongation can happen at any time when you start and stop. But if you take the drug chronically, it's rare for it to prolong later on. But starting and stopping, you can. So you may say, well, I took 250 micrograms before and that was fine. I missed 3 doses, I'll get back on it. No, you have to come in the hospital because you could have torsade. So that's what we do. So pretty much that's the story with dofetilide and Tikecin. I'd like to open up for any questions.
So what's the goal, the optimal goal for Tikecin to prolong the QT interval? Or
No, the optimal goal is to convert them to normal rhythm. We know the QT interval will increase probably 20 to 25% in most patients. So as long as the corrected QT interval is not more than 500 milliseconds, then we're in good shape. Then we continue the drug.
When do you normally see the conversion?
I've seen it after the first dose.
Mhm.
I've seen it after the 6th dose.
Right, okay.
Anytime. Conversion is harder the longer you've been in AFib.
Mhm.
Conversion is harder the larger the left atrium.
Mhm.
The conversion is harder in the older patients. In fact, I think I have 2 people coming in tomorrow to take us.
Okay.
One has a pacemaker.
Mhm.
Okay, he's 92 years old.
Oh, goodness gracious.
And this guy was very, 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 very functional part of that time, living independently. He's in atrial flutter and is almost bedridden
Oh.
because his
yeah.
cardiac output's dropped over 30%.
Mhm.
His ventricular function is normal. I think he also has an amyloid heart,
Mhm.
but he's failing. He's doing terrible. They're talking about hospice. I'm like, let's see if I
At
can get him
least
into
try.
normal rhythm first,
Mhm.
and maybe he'll get better. So he's one of the patients. So with the pacemaker, as we talked about, he's gonna have a wide TRS complex. In fact, that's his EKG for the patient for tomorrow.
Is
So
that
we
patient
know,
coming here?
sorry?
Is that patient coming here?
Yes. I think we have 2 coming in tomorrow.
I knew we had one. I'll look at the schedule
I
again.
just saw this patient 3 hours ago.
Yeah, great.
So-
That'll be good.
And he's, because he's failing his senses, do whatever you can.
Right.
Make him better, because
Bless
they're talking, as they're talking.
Has he
about
been in
hospice.
AFib very long?
No.
Okay, just started.
Only about 6 weeks.
Okay.
But he was not anticoagulated when I saw him 3 weeks ago.
Mhm.
Fortunately, he didn't have a stroke.
Yeah.
Now he's been on his anticoagulation. That's another thing. Every one of these patients, we have to be absolutely certain that they have not missed 1 dose of their anticoagulation. If they've missed 1 dose of their anticoagulation over the past 3 weeks, they don't get admitted. Okay, because they could have a clot. You can have a clot by missing 1 dose of Eliquis, Xarelto, or Pradaxa. So if they've missed any doses within the past 3 weeks, they go home. And the clock restarts. They have that 3 full weeks of anticoagulation. The highest risk of a stroke is when we convert them from atrial fib or flutter to sinus rhythm.
Mhm.
But we have to be absolutely certain, 3 weeks, minimum continuous, uninterrupted anticoagulation. And I tell them that 100 times.
Do most of them have a decreased cardiac output?
No.
Okay, so
Actually,
that's just him.
both of the
unusual.
patients coming in do not. They both have normal heart function. They have normal systolic function, but some do. And that's a good point, because if somebody has coronary artery disease, we only have 3 drugs. If somebody has had a heart attack, we only have 2 drugs to treat atrial
Mhm.
fibrillation, amiodarone and this.
Mhm.
And this drug's safe. There's only 2 drugs safe in people that have had heart failure, amiodarone and this. That's it.
Yeah.
There are no other drugs to treat AFib.
So you start,
As far as the side effects.
Yes.
First, you wanna know about the arrhythmias. Palpitations.
They
you
may
wanna know
have
about
some.
dizziness,
They could, usually not made worse by the drug, usually just made worse by their arrhythmia.
Okay.
Yeah, so they may come in complaining of palpitations, but the palpitations, I've never seen palpitations get worse on Dofetilide.
Okay.
In fact, I've had patients, they get a dose or 2, they convert, oh, I feel great.
Mhm.
And they notice the big difference.
so when they get the first dose, whatever time they get it, it's going to be timed exactly 12 hours after that?
As close as you can get. I tell my patients as an outpatient, plus or minus 2 hours. Yeah, usually it's fine by that. But, so we prefer to have them in on a Monday or Tuesday. We'll only admit on Monday or Tuesday. And if at all possible, I'd like to get 2 doses in the first day.
Mhm.
So as soon as they hit the floor, if we can get a creatinine for me, get a BNP, and get the EKG, as soon as they hit the floor, that way hopefully we can get 2 doses in. So if they come in tomorrow, they'll get 2 Tuesday, 2 Wednesday, 2 Thursday, home first thing Friday morning.
You don't need a PT and INR.
Do not, unless they're on warfarin. If they're on warfarin, then I like to have that, because if they go subtherapeutic, I'm not gonna give the drug. So that's a good point.
So the first day?
I don't use a lot of Coumadin.
If it's a late case, you still want to get the second dose in before 12 hours? Like-
No, I think if they get in late, then we'll have to do. So if they come in on a Monday afternoon, then they get 1 Monday, 2 Tuesday, 2 Wednesday, 1 Thursday, home Thursday, noonish or 1 o'clock. I usually like to watch them at least 2 to 3 hours after the last dose, unless they get like a 10 or 11 p.m. And then they go home first thing in the morning.
When you discharge them, or does your office already provide them with all their follow-up information and
I usually tell them,
discharge instructions?
before they come in, I usually tell them I wanna see them within 2 weeks following discharge. Usually 2 weeks, and then I give them their prescription when they leave. Since we have Epic, I can do it straight on Epic.
And I do think that Elena has been talking to his office person, Wendy, about discharge instructions, what we'll be able to print out. So hopefully we'll have some of that this week.
Good.
I know she's been on the phone with her last week.
You should have it all.
Several
If not,
times.
I'd be more than happy to
Because we
bring it up
can,
with me.
we can put it into our Epic system and then we
Right.
can just print it off.
So usually what I do when the patient comes in, say if they're in tomorrow morning at 7 o'clock.
Right.
As soon as they hit EKG, BNP, and then call me, and then we give them a dose. Then usually I come here at noon, that'd be 2-3 hours after the first dose,
Right.
and I can see that first EKG.
Yeah.
Okay, I'm usually here at noon, except on the discharge day, then I'll be here first thing in the morning. But that's good, I like to see the morning EKG when I make my rounds at
Mhm.
noonish. If I come beforehand, I don't know what that first EKG showed.
Right. Yeah.
Any other questions?
What happens if they don't convert?
That's a great question. 2 options. One, I might cardiovert them here before he leaves. This 92-year-old guy, because
Mhm.
he's failing, if he doesn't convert, I might cardiovert him just because he feels so bad. I mean, he's talking about going into hospice, that's how bad he feels. There may be many other reasons why he feels like this, but this is the one thing I can correct. So I might cardiovert him on Friday morning, depending on how things go. Maybe, I don't know, talk to his son a little bit more. But usually, I send him home, whatever dose it is, and see him in the office in 2 to 3 weeks. I give them, and I've seen a number of patients that don't convert initially and convert within a couple of weeks. So, so when I see them then if they don't convert, then we bring them in for cardioversion, because the success rate's dramatically better in converting and maintaining normal rhythm if they're on the drug first.
Oh, that's good.
Great questions.
Mhm.
Well, I look forward to working with you
Yeah.
all, and see you tomorrow.
All right, yeah.
So, Mr. Strickland